I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. For centuries, narcotics were the best way to manage severe pain. Now, with a cloud over opioids, what else can patients do? This is the People's Pharmacy with Terry and Joe Graydon.
Dr. Sean Mackey is a specialist in pain management at Stanford School of Medicine. He says there are many strategies in addition to opioids that can help people in pain. How can our healthcare system change from callousness to compassion for people who are suffering?
Because of the epidemic of opioid addiction and overdose deaths, doctors have become reluctant to prescribe drugs like oxycodone. What has that meant for people with severe chronic pain? Has the pendulum swung too far?
Coming up on the People's Pharmacy, do we need a revolution in managing pain? In the People's Pharmacy Health Headlines, many states have been lifting restrictions put in place last year to slow the spread of COVID-19. That's because COVID case reports had been falling for a few months. That has changed. Over the last week, case reports are up in more than half the country. The rise is quite steep in some places, including Nevada, Arkansas, Utah, and Missouri. Several counties in Texas also have high rates of new cases, along with counties in Virginia, Idaho, and Georgia. Another indicator is per capita hospitalizations. They're up in Missouri, Nevada, Arkansas, Florida, and Wyoming. California is also seeing a surge. In Los Angeles County, experts have seen a rise among unvaccinated people attributed to the Delta variant. As a result, officials are now recommending that people wear masks indoors in public settings such as grocery stores, workplaces, and theaters. At least 20% of the infections around the country appear to be caused by the Delta variant, which spreads more rapidly than other strains of SARS-CoV-2. Current vaccinations do seem to protect against it, however, prompting increased encouragement for people to get vaccinated.
Healthcare workers are especially vulnerable to COVID-19 if they haven't been vaccinated. A new study shows that the quality of the masks they wear makes a huge difference in their risk of catching COVID. British researchers gathered information most of last year with regular COVID testing. During that time, national guidance was for healthcare workers to wear surgical masks. Such face coverings don't fit tightly and are not designed to block aerosolized virus particles. Staff caring for patients infected with the coronavirus were 47 times more likely to contract the infection than those on non-COVID wards. However, after they switched to high-quality FFP3 respirators, the rate of infections dropped dramatically. These special respirators fit tightly and filter out aerosol particles. The investigators conclude that surgical masks are not adequate to protect against an aerosolized virus such as SARS-CoV-2.
Early in the pandemic, people were concerned about the possibility of surface spread of the virus. Lysol and Clorox brand disinfectant wipes were hard to find. A new study from UC Davis, published in PLOS One, suggests all that wiping might have been unnecessary. The research team sampled frequently used surfaces in UC Davis Medical Center during April and August of 2020. 11% of the samples from April contained SARS-CoV-2 RNA. By August, only 2% of the surfaces sampled yielded viral RNA. The RNA was not infectious. The scientists confirmed that gene sequencing technology is more sensitive than previous techniques for detecting viral contamination on surfaces. However, they concluded that contaminated surfaces are not a major means of transmission.
The FDA has just approved the first new weight loss medication in 7 years. New is not exactly the best way to describe Wegovy. The name is new, and so is the dose, but this drug, known generically as semaglutide, was first approved for type 2 diabetes as Ozempic in 2017. This self-injectable drug helps control blood sugar by increasing insulin release from the pancreas and reducing the amount of glucose released from the liver. Because semaglutide slows stomach emptying and reduces appetite, the manufacturer tested it for weight loss. Over 16 months, people taking Wegovy lost an average of 15% of their body weight. Those on placebo lost 2.5% on average. Adverse reactions associated with semaglutide include nausea, vomiting, diarrhea, and stomachache. Thyroid tumors, pancreatitis, gallbladder problems, kidney trouble, and depression are more serious potential complications. It's not yet clear how much Wegovy will cost, but Ozempic can run over $800 a month for people without insurance. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The opioid epidemic has captured headlines for years. But are there people who need these powerful pain relievers? What else can they do to manage their pain?
To answer these questions, we turn to Dr. Sean Mackey. He's Redlich Professor and Chief of the Division of Pain Medicine in the Stanford University School of Medicine. He's also Director of the Stanford Systems Neuroscience and Pain Lab, and holds appointments in the departments of anesthesiology, perioperative and pain medicine, neurosciences, and neurology by courtesy.
Welcome to the People's Pharmacy, Dr. Sean Mackey.
Hi, Terry and Joe. It's great to be here with you, and I really appreciate your taking on this important topic.
Well, Dr. Mackey, you are a pain physician. And you've described this as a very complex problem. And I always wonder, how do we even communicate or define pain? A lot of times when you see the doctor and you're complaining of pain, they say, well, on a scale of 1 to 10, where's your pain? And I often wonder, well, for my mom, a bellyache was like a 12. I mean, she was like, oh, I can't stand it. And for Terry's mom, she could break her leg and you'd ask her, how's the pain level? And she'd say, oh, maybe a 2 or a 3. So it seems like such a subjective thing. How do you, as a pain physician, deal with this subjectivity?
Well, I think you just hit the main issue right there is how do you take something that is inherently subjective and make sense of it? And, just to, help ground people, to give people a frame of reference. If I, were to ask you, Terry, how strongly do you feel about Joe? How strong are your feelings? On a scale of 0 to 10, you might give some number, but it's absolutely meaningless. It only means something to you.
Right.
And that's the issue around pain, is that pain score is unique to that individual. It is encompassing everything they bring into that experience of pain, if it's an acute pain episode or over many, many years. And so I do find the pain score to be of somewhat value in the acute pain setting after an injury, not as much in the chronic pain. And the thing that I've learned a long time ago is that when somebody comes in with a pain score that's really, really high, and they seem to be moving around okay, they seem to be getting on with things, you never challenge somebody on their pain score. You just accept it as it is, you move on. And, the point is figuring out how you can best help them to be able to achieve a better quality of life, to be able to be more functional, to be able to get back to doing the things that they used to do before the pain.
How do we define pain?
There's a number of definitions. The one we tend to rely on came out of our International Association for the Study of Pain many years ago, and we define it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Now, let's just skip all that stuff towards the end for a moment, and let's just focus on the first few words. It's an unpleasant sensory and emotional experience. By defining it as an experience, it means it's subjective. But also within that, it means that it has this sensory component to it, which is what we're most often thinking about in terms of pain, but it also has this emotional aspect of it. And you can't easily disentangle those. You can't really separate those because they're part and parcel. And the thing about pain that is so amazing, it's such an incredible, useful experience. It's so wonderful because it is so terrible. It's so wonderful because it's so terrible, because it keeps us out of danger. It serves a survival basis for each and every one of us. We all wish that we didn't, have to experience pain, but, we've been able to see that firsthand. There are, unfortunately, kids that have a genetic defect that don't experience pain. And what we've learned is they have tragic consequences. They put their hand on a hot stove and don't realize they're burning it. They scratch, their corneas off because they can't feel that they're scratching their eyes. So pain is incredibly useful until it goes bad. And that's the main issue that we're dealing with here in chronic pain, is this tragically terrible experience that, once again, is very individual. It's very subjective.
And it has a profound impact, as you've already alluded to, our entire lives. It's not just the pain itself. It's the emotional overlay. It's all of the other factors. I lifted a generator when we were in the middle of a nasty snowstorm here in North Carolina back around December, January. And shortly thereafter, my back was a mess. And it wasn't just a couple of weeks, which is sort of what I was expecting, because I've dealt with chronic low back pain pretty much all my life. But this severe pain persisted. And weeks went by, and then months went by, and I did everything I could. I went to physical therapy. I had acupressure and acupuncture. I went to a chiropractor. I went to a massage therapist. I was doing it all, and I was beginning to be resigned to the idea that maybe I would never play tennis again, and maybe I wouldn't be able to hike again, and maybe my life had just changed permanently, and I was in a pretty deep, nasty place with that back pain until it went away. And all of a sudden, I was like reborn. The pain was gone, but the emotional distress was also gone. And here's the weird thing, Dr. Mackey. I forgot about it. It had been intrusive almost every waking minute for those several months. And that was all I could really think about and try to avoid as best I could, not very well. But when it was gone, it was gone.
Yeah, that's a great story. And you've just described what so many people often experience after having an injury, after having a surgery, where their pain can persist. And what you see is, after a period of time, your brain starts to rewire in the face of that pain, and you start to develop repetitive thoughts about the pain. Is this ever going away? Am I ever going to be able to get control of this pain? Is it just going to get worse and worse? And this is the way we're wired as human beings. And this catastrophizing, this degree, what we call those thoughts and those emotions that go behind it, the anxiety, the feelings of getting down or feeling depressed, they take a terrible toll on people's lives. And, just to make it clear, it's not just the person. It's also their family and their friends around them. It's the entire social, network. And I think this is an area that's incredibly underappreciated in the area of pain management, is just the social impact that pain has on the individual living with pain, but also on everybody else.
Can you tell us a little bit more about that, please?
Certainly, and we've been doing research on that. So you introduced me as a physician, and I am, but I usually think of myself as a physician scientist because I've been doing research in the area of pain for now over 20 years. And, just taking work out of our lab at Stanford, we track, if you will, pain in everybody who comes into our clinic. We want to see how they're doing with their treatments, how they're doing over time. And some of the things that we track are things like physical, psychological, and social functioning. So we've published now a number of papers which show that one of the key indicators of how people are doing with their pain is the degree of social isolation they have. How withdrawn do they get when they have pain? And what we're learning is that a lot of our preconceived notions about the way pain works is quite wrong in this context. In other words, we usually think that when your pain goes up, you end up have lower function. You do less things. And Joe, I'm sure you were doing less things when you had pain.
I wasn't playing tennis.
You weren't playing tennis. And then what happens is we tend to think of it as, well, you start to get kind of depressed and angry and anxious, and that's the usual routine. But what we learned, we can really model this, is what's going on is your pain goes up, your function goes down, and then you start to withdraw socially. You start to withdraw from your community, your friends, you start doing less with them. And it's that makes you more depressed, more anxious, and more upset. And we often don't appreciate that. We leave out that social aspect in the context of our description of pain. And I'm just bringing it up because I think we need to be paying more attention to those aspects, how it's impacting the family and friends, and how the family and friends are impacting the person.
What should family and friends do or say when they know someone is in that deep, dark hole and really suffering?
Yeah, that's a great question because there's no easy answer here. On one hand, you want to be clearly supportive of that person. You want to, help them out during this period of time. And yet you don't want to do so much that you're now kind of taking over all of their activities of daily living, because that can just further enable a degree of disability and, disuse of their muscles. So it's a fine line there. And I think that the number one thing that people can do, the family can do, is they can help ensure that the person living with pain, that their pain is being validated, that they believe them. Because that's probably one of the biggest issues that I see with patients is they don't feel like people believe that they're experiencing what they're experiencing. And that degree of validation can be, very empowering, and people at least feel like they're being supported. They still have to live with their pain, but they feel they've got their family behind them.
You're listening to Dr. Sean Mackey, the Redlich Professor and Chief of the Division of Pain Medicine at Stanford University School of Medicine. He's director of the Stanford System's Neuroscience and Pain Lab. Dr. Mackey also has courtesy appointments in the departments of anesthesiology, perioperative and pain medicine, neurosciences, and neurology.
After the break, find out how acute pain can turn into chronic pain.
Should we consider chronic pain a completely separate medical condition?
What are complex regional pain syndromes, and how can you manage them?
Dr. Mackey offers a 6-pronged strategy to tackle pain.
How could doctors worried about prescribing opioids use this approach?
You're listening to The People's Pharmacy with Joe and Terry Graydon. The People's Pharmacy podcast is supported in part by CocoVia Memory Plus. CocoVia cocoflavanols support both cardiovascular health and cognitive function by promoting healthy blood flow, transporting oxygen and nutrients to vital organs and muscles, including your heart and brain.
CocoVia Memory Plus has 750 milligrams of cocoflavanols, the plant-based nutrients from fresh cocoa that have been proven to help boost memory.
CocoVia Memory Plus is backed by 4 clinical trials that demonstrate improvement in 3 different aspects of memory: long-term memory, spatial memory, and word recall. The studies show improved brain function in just 8 weeks.
You can try the benefits of CocoVia Memory Plus with a 25% discount off your first month. Use the code PEOPLES25. To get the full benefits, take it daily for 8 weeks. CocoVia is offering People's Pharmacy podcast listeners a 10% discount on subscriptions. That code is Peoples10. Learn more at cocovia.com. Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. If you'd like to purchase a CD of this show, you can call 800-732-2334. This is show number 1178. That number again, 800-732-2334, or you can place the order at our website, peoplespharmacy.com. You can also download the podcast from our website or from wherever you get your podcasts.
The People's Pharmacy is brought to you in part by Verazana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
Today, our topic is managing pain. What do we do when pain becomes chronic?
We're talking with Dr. Sean Mackey, Redlich Professor and Chief of the Division of Pain Medicine in the Stanford University School of Medicine. He's also Director of the Stanford System's Neuroscience and Pain Lab and holds courtesy appointments in the Departments of Anesthesiology, Perioperative and Pain Medicine, Neurosciences, and Neurology.
Dr. Mackey, we sometimes hear that a person gets hurt, that's an acute pain, and then it lasts. And then it becomes a chronic pain. How does acute pain convert itself into chronic pain? And should we be considering chronic pain as a medical disorder all of its own?
Yeah, so let me take the second one on first because that's a little bit easier for me to answer. And I was fortunate to be on the Institute of Medicine committee that wrote the pain report, the Relieving Pain in America, in which we put forward a blueprint for how we should approach pain in this country. And in that, we put forward this notion that pain, while it can be a symptom of another condition, that when it becomes persistent, when it becomes chronic, it can become a disease in and of its own right. One that fundamentally alters our nervous system, our endocrine system, our inflammatory system. And the best analogy I can give you is probably diabetes. And nobody questions that diabetes is a disease, but diabetes doesn't start as the disease of diabetes. It starts as, for instance, impaired glucose tolerance. You eat a donut and your blood sugar skyrockets. And it slowly over time progresses into this frank disease of diabetes. Chronic pain is much like that. You can have, for instance, an acute injury, or you can have, for instance, surgery. And what we've learned is that a small percentage, and it can be anywhere from, say, 1 to 10% of people after a significant surgery or injury, Joe, your back pain injury being an example, about 10% of people will go on to have chronic pain. And you asked a question, what's this distinction and what happens here? And part of the problem is the way we think of it, because we tend to think of it as a transition, is how it's been referred to. People are either in acute pain or chronic pain. What we're learning now is that there is no arbitrary transition, that it's a continuum. And that means that somebody is progressing from this acute pain state, and over time, the neural circuits, the nerve patterns in one's spinal cord and one's brain are starting to alter over time, and they start functioning abnormally. You see changes in the inflammatory system and in the immune system that over time starts to set up this chronic pain state. And a large part of the research interest these days from our group, other groups, and the NIH is to understand what are the mechanisms behind this, because if we can find the mechanisms on what causes it, we can then target it and prevent it. But on top of that, also find what predicts who is going to be vulnerable to getting chronic pain after an injury or after a surgery. Because we've learned that this doesn't happen to everybody. It's only a small percentage. And if we can identify those people who are more likely to develop chronic pain after surgery or after an injury, we are so much better off trying to prevent that than treating it after it's the horse has left the proverbial barn. And we have found some factors that predict this. What we've learned is, in many cases, let's just take surgery, because this is an area of active interest in our group, that what you bring to that operating room table, in other words, what your whole life history that you bring to that surgery, often has more bearing on whether you'll develop chronic pain than what the surgeon is actually doing to you. And the reason for that is that we bring in our whole life experiences of how we experienced pain as a kid, as a young adult, how we were treated with pain, and whether we also had any other type of conditions such as a history of anxiety, PTSD, depression. All of these things can set up your nervous system and make it vulnerable to developing chronic pain after that surgery or after an injury.
Can you give us some examples? I mean, I'm thinking about an acute situation where somebody breaks an arm, it hurts, but it gets set and cast, and a couple of weeks later, it's pretty much gone and better, and when the cast is removed, the pain is gone. Whereas in a chronic situation, a person might be in an automobile accident, or we've heard from veterans who've been in Iraq or Afghanistan and have experienced some pretty dramatic trauma and almost died, and now they are left with what we would call chronic pain 24/7, 365 days a year.
Absolutely. So what you've just described, first of all, with the men and women who come back from Iraq and Afghanistan is tragic. And it illustrates the problem we have in society around pain. And that is, we are getting so much better at keeping people alive during wartime, from cancer, from traumas. We've got these great medical systems to keep people alive. But we're now finding that the treatments that we're using to keep them alive are now generating a large number of people with chronic pain. So let me just give you an example of a young woman that I've cared for many years. Her name is Sandra. And, Sandra was in her early 20s, and she was in upstate Pennsylvania. She was driving to college, and she was listening to Britney Spears on the radio when her car was T-boned out of the blue, and she had an ankle injury, taken to the emergency department. She was ultimately released. And the problem is the pain in her ankle, despite not having a significant injury, never went away. It never went away. That was probably 10, 11, 12 years ago now. She ended up getting this terrible, burning nerve pain condition we call complex regional pain syndrome. And this is a pain condition that nobody ever wants, because it's like a blowtorch on your foot, your ankle, your hand, or your arm, 24 hours a day, 7 days a week. So, Sandra she lives in Florida now. She comes out and sees me on an intermittent basis for therapy. And, she's doing very well. She's got her, I believe her second child now. And she is working her way through this. She's learned coping mechanisms on how to deal with it. We've put various treatments together. It really is a whole package. But there's a perfect example somebody who was otherwise healthy, who had, a motor vehicle accident, but not something that you would expect would end up with a chronic debilitating condition, gets this terrible nerve pain condition. And this happens with great frequency.
I think a lot of people don't know that much about complex regional pain syndrome. And I'm wondering if you can tell us, are there treatments for it? Are there ways? Obviously, you and Sandra have found some ways to help her. What are the usual first steps for someone who has such a situation?
So the first step, and I'm going to generalize here, the first step with anybody that you're assessing who is experiencing chronic pain is to get a good assessment. The history is 90% of it. The physical examination is only a small percentage of it, and it's usually confirmatory. We want to be able to understand what's going on with the person. both from the medical standpoint, the biological, but also from those psychological and social aspects, because we don't want to just look at Sandra as a foot, ankle, and leg. That would do her a disservice, because this pain has taken over her whole life. We want to look at the whole person. So first, that history and physical examination, we want to develop then a strong diagnosis. Is this really complex regional pain syndrome, this terrible neuropathic pain condition? After confirming that, it is usually a multidisciplinary approach to treating people like Sandra and others that really wins the day, that can help make the biggest impact. And the way I think of this is that there's 6 main buckets, if you will, of this multidisciplinary treatment. The first are the medications. And this is in no particular order, by the way. I'm not prioritizing meds. But medications. 2 is we have procedures. These are nerve blocks. These are minimally invasive surgeries. 3 are psychological and behavioral approaches. This is pain psychology, for instance, often very underutilized. 4 is physical and occupational therapy approaches, physical rehabilitative approaches, which particularly for CRPS are probably one of the most important aspects, is to get people reactivated. 5 are what has been referred to as complementary and alternative medicine approaches. These are over-the-counter nutraceuticals. These are the vitamins that you can purchase in various stores, as well as acupuncture and other treatments. And then 6 is probably one of the most underutilized treatments in chronic pain, which is self-management. And self-management doesn't mean just suck it up and deal with it. Self-management involves organized, peer-led groups that involve people living with pain who are sharing their experiences and developing learning and coping strategies on how to better manage it. So it's those 6 things, and it's best done with somebody like Sandra and other people living with pain to put those together, particularly in a team-oriented environment, a team approach, because it takes a team to really manage somebody well who's living with pain. And that's where you're going to get the most wins. And by the way, I'll just make a pitch. That approach is what we put forward as the follow-up to that IOM pain report. And so I was honored to co-lead the development of the National Pain Strategy with Linda Porter from NIH on behalf of Health and Human Services. And we put forward a strategic plan on how to reshape our country's approach to pain. And it's got a multi-pronged approach, and we're just pushing hard to get legislators and policymakers and others behind this, because if we can enact this, we can have a huge impact on pain in this country, and also, by the way, as well as the opioid crisis.
Well, let's pause right there, Dr. Mackey, because we are facing what some people have called the opioid crisis, the opioid epidemic. It was number 1. You said there's 6 buckets, and the first bucket was medications. And we've heard, and I think it's probably true, that we're in the middle of a pain epidemic in this country. 1 out of 3 people may be suffering from serious pain or chronic pain. And for decades, opioids were considered an appropriate way to treat severe chronic pain. I'm thinking about the patient who's in an automobile accident and had 20 broken bones, or had a surgery that went bad and they are in, chronic severe pain, or one of those veterans that you talked about from Afghanistan or Iraq who's got blown up by an IED. And so the role of opioids has been now so politicized and is now so controversial. Many of these patients no longer have access to drugs that they were taking successfully. They never increasing the dose, never abusing it, taking them for, in some cases, many years under a doctor's supervision. But now many of your colleagues are afraid to prescribe opioids because it's become such a political, almost an emotional issue. And they're afraid that they may be chastised by their colleagues or by their local medical groups.
Oh, well stated. It's an absolute tragedy what is going on right now, and it's a tragedy on both sides of it. And we are unfortunately behaving as a society in the typical reactionary mode that is trying to address one problem very aggressively and yet having terrible unintended consequences, in this case, for the people who are living with pain. So, before commenting further, I think it's important for the viewers to know that I am not pro-opioid. I am not anti-opioid. I am pro-patient. When I mention pharmaceuticals, when I mention the medications in that first bucket, there's about 200 different medications we can use for pain now, only 20 of which are opioids. And my view on these is that they are a tool. They are a tool that can be used effectively to help manage pain, and they have been used effectively. I have seen both sides of this at both a professional level as well as on a personal level. So I have seen the absolute destruction that opioids can bring to a person who becomes addicted or overdoses, and then also the impact it has on their family. And it is, once again, it's tragic. And at a personal level, I've lived with this because I come from a family with a deep, deep history of addiction to both alcohol, to opioids, and others. I have lost family members, close family members, to these substances. So I get it. I really do get it. And on the flip side, I have seen patients that I have cared for and others have cared for whose lives have been transformed by opioids, and it allows them to get back to work. It allows them to engage with friends and family. They behave themselves on the opioids. They may have been on them for many, many years. And now these people are being victimized. They're being told they're addicts, and they are simply trying to find ways to maintain their level of pain control without being ostracized and having fingers pointed at them. It is, and I get the reasons why society has overreacted, because this opioid epidemic is a very real thing. But we just have to be compassionate and mindful that our actions, particularly our policy actions, don't have unintended consequences. And unfortunately, that's what's occurred. Giving you some examples, it's gotten just absolutely crazy out there. So I see patients in the clinic probably several days a month. Most of the time I'm doing research these days, and I just had back-to-back patients last week. One is he's a senior person here at Stanford, who clearly, I'm not going to name names, who's taking literally like a half a Vicodin a day for chronic neck pain that he's had forever. And this person is more productive than the three of us put together will ever dream of being. And he reached out to me because his primary care doctor is now insisting that he comes off his opioids. And this small amount of opioid is helping him to function throughout the day. It's just absolutely insane. And he is, by the way, incredibly bright and has tried all these other approaches, and he does many of them. But this small amount of opioid helps keep him functional.
You're listening to Dr. Sean Mackey, Redlich Professor and Chief of the Division of Pain Medicine at Stanford University School of Medicine. He's Director of the Stanford System's Neuroscience and Pain Lab.
After the break, find out how Dr. Mackey treats his patients who are on opioids.
If people miss too much work due to pain, they may lose their jobs and their health insurance. What sorts of complications result?
How can we address disparities and inequality in pain management?
How can we help people in a compassionate way without making them feel invalidated?
Do we need a revolution in treating pain? Where do we start?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. KAYA Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's Kaya Biotics.com. Use the discount code PEOPLE for $10 off your first purchase. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. To purchase a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show, number 1178. That number again, 800-732-2334, or you can find it at peoplespharmacy.com. You can also download the free podcast from Apple, Stitcher, or from our web store. We invite you to consider writing a review.
The People's Pharmacy is brought to you in part by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KayaBiotics.com.
Have you ever suffered from persistent pain? It can dominate your life. Is there a role for opioids in managing chronic pain?
Our guest is Dr. Sean Mackey, Redlich Professor and Chief of the Division of Pain Medicine at the Stanford University School of Medicine. He's Director of the Stanford System's Neuroscience and Pain Lab. Dr. Mackey also has courtesy appointments in the departments of anesthesiology, perioperative and pain medicine, neurosciences, and neurology.
Dr. Mackey, you were just talking about a colleague at Stanford who has done very well on half a Vicodin, which is not that big a dose. And you say he is functioning really well, and his physician is trying to get him off the Vicodin, understandably, because there's so much emotion around opioids. What's he going to do? And can you tell us about the other patient you were about to talk about?
Sure. I think what he's going to do is he's going to see one of the docs in our pain center, and we are going to either write a letter to his primary care doctor and say he should be on this, please continue to write it, or we'll take it over for some period of time. You know, my hope is that some of this overreaction, this craziness, will help slow down. And we're starting to see some of this. So the CDC has recently released a correction or a clarification to the original 2016 CDC opioid guidelines. And the reason for this is that many people were weaponizing the CDC opioid guidelines. They were taking these out of context, they were misapplying them and using them to forcefully taper people off of opioids. And the CDC, in a very thoughtful response, said this is not what we intended. They should not be used this way. Unfortunately, much of the damage has been done, and I don't blame the CDC for this. I'm not sure. There's not really blame here. We all hold responsibility in this crisis that we have. Everybody has some degree of responsibility. What we need to take a breath, pause, and let's not be guided by fear. These medications do have a role in some patients, even in some cases in these larger doses. And so had a patient that was in the Stanford Pain Management Center, and here's a guy who works, he has, similar to the other patient, he has a foot-ankle injury from dropping something heavy on it and crushing it. And he came to us, and he had been on high doses of opioids through fentanyl patches. And his primary care doctor wanted him weaned off. Now, this had been going on for many years, his use of the opioids and this pain problem that he's had, and he has tried every treatment imaginable. And he was on rather large doses. So we did what we usually do. We have a team conference. We have him seen by a physician, a pain psychologist, a physical therapist. We all sit around a lunchroom table and we discuss each patient over bad Chinese food. And there was a lot of debate because even within my own center, we're finding more and more people having a degree of fear around prescribing with people on higher dose opioids. But the psychologist came in and said, you know what? This guy is a functioning member of society. He's doing everything that's been asked of him. And every time he's tried weaning down, 3 times he's tried weaning down, he's ended up having to drop out of work. He's tried all the therapies that I can provide the psychologist. And the physician said, yeah, and he's done everything that we've asked him to do with all the other medications and the approaches. And after a long conference, while, we were concerned about the doses he were on, our recommendation was leave him alone. Let him stay on those doses. We've got a guy that's working a more than full-time job, paying his taxes, doing all the things that we would want with somebody who's out there. And this has been an effective tool for him. And this is the thing we need to remember. We can't generalize these tools and make broad statements across everybody. For some people, they're going to run into real problems with opioids. They have a vulnerability to them. They're going to get addicted, and they may overuse them to even having an overdose. And again, on the other end of the spectrum, we're going to find people whose pain is very opioid responsive and who are behaving themselves and doing everything that's been asked of them. And this particular tool plays a useful role, not as a first-line agent, not as a second-line agent, maybe not even as a third or fourth line, but they do play a role in that multidisciplinary treatment approach that I was alluding to earlier.
And of course, if someone is no longer able to get to their job and work, then they lose their health insurance, generally speaking, and that creates a whole lot of complications for treating pain.
Oh, my. So, now you're getting into some of the real challenges we face as a society, which are the underserved people, the disparities in pain treatment, because we see huge disparities across socioeconomic status. In other words, people who are employed or not employed, the level of insurance you have. All of these have a huge factor. On top of that, geography plays a role. We have, we're blessed here in the Bay Area with having at our center just about every resource that you can imagine. But you go just, 50 to 100 miles inland and you've got broad swaths of Central California with underserved populations that have little healthcare resources, particularly specialized pain resources. And so this is one of the challenges that we have. These are some of the things that we're working on here at Stanford, which is how to ultimately deliver high-quality care to these underserved areas. And these are some of the challenges that we're all going to be facing over the next several years, is broader dissemination of our knowledge and these treatments so that more people can get it.
Is that the answer to how to address the inequality in access to pain management?
Well, I think it's obviously a complex issue that involves one part of it. I think another part is education. The problem that we have in healthcare is, and I'll only speak about physicians. Physicians get on average about 7 hours of pain management training in medical school, which just really isn't much. And when you compare it against a veterinarian who gets about 40 hours, that means it's great if you've got a dog who is in pain, but not so great if, you're taking your spouse in for pain management. So we need to do a better job across the country in raising the level of knowledge and skills for all health professionals who care for somebody with pain. And these are just some of the things that we're working on. These are some of the things that we called forward in the National Pain Strategy.
Dr. Aki,
Yeah.
I think one of the things that is very distressing to us, because, again, we have received hundreds, if not thousands, of reports from people who visit our website with chronic pain, if it was an animal, a dog, a cat, a horse, the veterinarian and the owner or the companion, people wouldn't let that animal suffer. And yet we hear from people who are in such severe chronic pain being cut off from opioids, maybe a little bit like the two patients that you mentioned. And there's almost a callousness, like, well, just get over it. And I don't think people can just get over some of their severe chronic pain.
Well stated, Joe. I think that's exactly it. I've heard health professionals hearken back to the days when, pain was considered good for you. It was considered a source of strength to experience that pain. And, maybe we should go back to those times. And I just think about that and think that's absolutely crazy. We do not want to go back, several decades or even earlier when, we didn't have appropriate treatments for pain for people, particularly dying from end-of-life cancer, for acute pain issues, and I would also say for these chronic pain issues. And we as a society need to develop more compassion. And there is no more critical time than right now to do it, because this issue of chronic pain that we've been talking about is only going to get worse in this country and globally. And the reason for it is very simple. We're living longer. As I alluded to earlier, we're doing a better job and we keep people alive from cancer, but now they get neuropathic pain from the chemotherapy and the radiation therapy and the surgery. We keep the vets alive from Iraq and Afghanistan, but they come back with post-amputation pain and traumatic brain injury and other types of chronic musculoskeletal pain problems. So we are creating every year more and more people who are living with chronic pain. And we need to find a way as a society to help these people and do it in a compassionate way without them feeling victimized and invalidated.
What do you see as the primary methods for addressing that?
I think we need a cultural revolution in the way we think of pain in this country and globally. Let me be clear that the challenges that we face in our country are not unlike the challenges that I've seen in other developed countries throughout the world. I mean, I go to Europe, I go to Australia. We're all facing the same problems. And the solution is, I think we need to increase public awareness of pain. We need to help people to understand that they don't have to suffer in silence, that there are resources available for them, that they can get help, and that it's not necessarily just a sign of strength to grin and bear it, but it's okay to reach out and ask for help. My father's a perfect example of this. So my father used to play a lot of competitive sports earlier in his life, and he had a lot of injuries. And for much of his life, he's had chronic pain issues. And he was one of those 100 million Americans, and he self-managed. He took care of it on his own. And despite my efforts, he would never listen to me. He would never listen to me. And he didn't start listening to me until the last few years when his pain has gotten rather severe and debilitating. And, now finally I'm in my 50s and my father for the first time is actually listening to me. And we're getting him help. We're getting him help. And I think that message, we need to increase public awareness. We need to direct people towards the appropriate resources. And then also we need to call for better ways of assessing and managing pain in this country, both in the acute setting that we talked about before, but particularly in this chronic setting. And we need to incentivize our docs, our healthcare professionals, our clinicians. We need to incentivize them in ways that it makes sense for them to spend more time with their patients. The problem, my heart goes out to the primary care doctors in this field because they get on average, 10, 12 minutes with each patient? We spend anywhere from an hour to an hour and a half on an assessment because we believe that's how long it takes to really understand the person. I can't imagine a primary care doctor trying to figure this out in 10 to 12 minutes. But primary care doctors and others who, are basing their fees off clinic visits don't get reimbursed much for that. We are reimbursed for the things that we do to patients.
Dr. Mackey, I just wonder how we can begin to revolutionize the treatment of chronic pain in this country using those 6 buckets that you mentioned, those various medications, the interventional procedures, the physical, rehabilitative, and occupational pain therapy, the pain psychology, because obviously a lot of primary care physicians don't have access to that team approach that you have asserted is so valuable.
Yeah, Joe, this is one of the challenges that we've been struggling with through the National Pain Strategy and through other efforts. And I think the first key in this is that we need to have closer relations between the specialists who do pain and primary care. We need to work collaboratively because the reality is not every patient needs a multidisciplinary team-based approach like what I described that we have here at Stanford. There's not enough of them to go around, and it's more than most people need. So we need to be able to, first of all, improve the education and the available resources to the primary care docs who are taking care of the easier stuff, if you will, that can be effective for a large number of people. And we need to help them and others recognize when to appropriately refer to a specialist. And then, ideally, be able to get them to that team-based specialist and bring those resources to bear. I'm pleased to see that there is growing awareness across the country, across the government in this space. I'm hopeful that some of the things that we've put into play through the National Pain Strategy and other efforts through the government are going to help make a real difference here.
Dr. Sean Mackey, thank you ever so much for talking with us on the People's Pharmacy today.
Oh, it's been a real delight to be here with you. And once again, I just can't thank you enough for taking on this important topic. It's really very timely, and I'm hopeful there's a number of people listening in that will ultimately seek out and get the care they need.
You've been listening to Dr. Sean Mackey, Redlich Professor and Chief of the Division of Pain Medicine in the Stanford University School of Medicine. He's also director of the Stanford System's Neuroscience and Pain Lab and holds courtesy appointments in the departments of anesthesiology, perioperative and pain medicine, neurosciences, and neurology.
And Terry, what were those 6 buckets that Dr. Mackey said were so important in this integrative team approach to pain management?
Well, of course, there are medications.
And opioids are one of those.
That's right, although there are many other medications
there are 200 different kinds of pain meds.
There are procedures. There are psychological and behavioral techniques. There's physical therapy and occupational therapy. There are some complementary and alternative medicine approaches like nutraceuticals and herbs, and there is self-management.
All very important. Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
To buy a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1178. The number again, 800-732-2334, or you can find it at peoplespharmacy.com.
When you visit the site, you can share your thoughts about today's show. How have you managed pain? Have you ever had trouble getting access to opioids? If you've used any of Dr. Mackey's buckets for pain management, please tell us how well they work.
At peoplespharmacy.com, you can sign up for our free online newsletter or subscribe to the free podcast of the show. You'll never miss another episode, and you can share it with a friend.
And this podcast will have a little extra question in it that didn't fit in the broadcast.
In Durham, North Carolina, I'm Joe Graydon.
I'm Terry Graydon. Thank you for listening. Please join us again next week.